Wow, I have a lot of hype to live up to here, so that's great. I'm really thrilled to see a big crowd. I think it's also, I was worried that we have a big auditorium, then it's a couple of people, it looks empty, but now we have a nice cozy space. So I'm going to divide my presentation here in a couple of pieces. Whoops. So talking a little bit about the numbers, epidemiology. As researchers, we love to talk about numbers and facts and figures and data, but that's only part of the story. So I don't want to spend too much time. I might could go on for hours and days about all of these numbers, but ultimately, what are we going to do with that? And I want to move that part of the conversation to health outcomes, but also the health of folks who are involved in the criminal justice system. And then finally, I want to look at how we can actually affect change that can promote public health and public safety. So a big aspect is sort of call to action that, so we're all going to leave here and save the world and all of that. But I think, I wanted to kind of outline some practical strategies that we in Arkansas can do right now. So this is not something, it seems like a very daunting task. Incarceration is a very complicated issue, but it's not beyond our means to change, and we don't have to wait 10, 20 years. This is something we can be doing right now. So I want to emphasize that. So first, some numbers, because as I mentioned, my epidemiology background forces me to talk about numbers. So 7 million people under correctional supervision, and these are as of now. So we have, that's people in prison, and just for those of you that may not be as familiar with the criminal justice system, I know many of you are, prison after people are actually sentenced, and then there's jail, which has quite a bit more, about 12 million people each year cycle in and out of jail. And that's usually prior to conviction while people are awaiting trial. So people can be held for a few hours, a few days, months, up to a year in general in jail. And sometimes held before being charged. And to give you to graphically depict this, how we divide it up, because again, we think a lot of times when we talk about incarceration, we think about prison cells. But that's only a small area. The arms of incarceration are very long and have a broad reach. And so we look at probation, so people who maybe they've completed their sentence, or in lieu of sentence, they're given probation, so they're in the community, but they're still under correctional supervision. So meaning they have to check in on a regular basis with correctional officers. And then we have correctional facilities themselves, and then people who are paroled, who are released from prison. So we have different areas where people are actually coming into contact with the criminal justice system. And many of you have probably seen this, but this, every time I see this graph, I still kind of shake my head at it. It's really quite striking. When you look at, we're going around, for many decades, the better part of the 20th century, and then we see tremendous spikes in levels of incarceration. And the majority of that is due to drugs. Drug incarceration, probably heard a lot of rhetoric about the war on drugs, who started it, President Richard Nixon, then Ronald Reagan and the Clinton years, and even today. However, the good news is we're seeing a slight downturn, about 2.4% drop over last year. So maybe, just maybe, across the country, we plateau and we're starting to come down a bit, but not all states. Unfortunately, Arkansas has a distinction of being one of the highest incarcerators in the nation. And you also notice this part of the country, we have very high rates of incarceration. So neighboring states, Oklahoma, Louisiana, Mississippi, these are all states with very high rates of incarceration. And by the way, just to kind of give you some additional context with the slide I showed before, our rate of incarceration now in the United States is the highest rate of incarceration not just now, but in the history of documented history. So just to put that in context, we've never seen incarceration rates like we have in this country today. And as I mentioned before, a lot of it was drugs. And so people say, well, we've got all of these, these people that are, high-level dealers, and that's why we had these mandatory minimum sentences in the 1980s to lock up people selling drugs. And even today we say, well, people in possession, those aren't the people we're arresting and incarcerating. We're arresting the dealers. We're arresting the people that we need to get off the streets. Well, that's not the reality. 80% of drug arrests in this country are for possession. So I am carrying a pocket full of whatever, whether it's crack cocaine, whether it's marijuana, whether it's heroin. There are varying degrees, obviously, of severity. But 80% is for possession. So in the bottom here, you see in the yellow, this is actual drug dealing, drug trafficking. The majority of these arrests are not for drug trafficking. And the majority of these arrests here represented by the orange bars are people that are really struggling with substance use disorders. They have addiction, and they actually, many of them need treatment, but they're winding up in the criminal justice system. And one elephant in the room that we just are going to have to acknowledge because it's a fact. Our criminal justice system is not just. We have tremendous racial disparities across our system, and we can't ignore these. We have to grapple with these front and center. So the arrests for drug-related crimes is quite stark, the difference between African Americans and Caucasians. And this is despite the fact that data shows us over many, many years, not just in the last 2 years, 5 years, 10 years, 20 years, if you look at racial groups across the United States, blacks, whites, Latinos, they use drugs at the same rate, 8 to 10%, relatively speaking. There's no statistical difference in terms of rates of drug use. So how could we have such a huge disparity in terms of who's arrested for drug use? It doesn't make a lot of sense. And unfortunately, this leads to the following. This is a litany, but I'm just going to read it because you just hear it and you're just, when's it going to end? So black Americans more likely to have their cars searched, arrested for drug use, jailed while awaiting trial, offered a plea deal that includes prison, longer sentences, disenfranchisement, having their probation revoked. And a lot of this is for similar crimes. So it's not that, well, are these folks, committing more serious offenses, more violent crimes? Not necessarily. We see things in the criminal justice system through a racially charged lens. And it has led to quite shocking numbers. Men generally are incarcerated more than women. But if you consider that African American men born in the year 2001, based on current rates of incarceration, 1 in 3 have risk for incarceration in their lifetime. 1 in 3, that's a third of an entire demographic being removed from society. The implications for their family, their communities, their neighborhoods. And this is a profound impact that is not just a year or 2 or 5, it's a generational effect that we don't fully consider all the time. And then, of course, during the introductory remarks, the collateral consequences, I think, are crucially important. Governor Hutchinson announced $27 million to put into the foster care system, and I applaud that, and that's great. What are the top 2 reasons for kids going into the foster care system in the state of Arkansas? Parental drug use, parental incarceration. I would like to see more commitments to those 2 areas, because if we want to get the foster system under control, we have to do something about drug use and addiction, and we have to do something about incarceration. And about half of people in prison have kids under the age of 18. So these are kids effectively growing up without a parent. What are the implications of that? It's beyond individuals. It gets into the health of families and the broader community. And the other thing is, this is concentrated in neighborhoods. Just as an example, I chose 2 zip codes in North Little Rock. Many of you may be familiar with these zip codes. So 6% of the population in Pulaski County, but 20% of returning prisoners. And you're talking about folks who come back, they may struggle getting housing, they may have challenges getting employment. So that it has potential, it has implications for the entire health of the neighborhood. So we have, again, these generational problems tend to persist. So now I want to sort of, talk a little bit about the health implications. So, we kind of looked at the numbers. We've got a lot of people going through the system. There are some, there are definitely some biases, implicit, explicit here. But then, who in general is going through this system? So, what are the health implications of all of this? Our social experiment with mass incarceration. Well, for one thing, people incarcerated tend to be sicker. So, again, just to give you some numbers, to give you some context, about 40% of inmates report having a chronic condition, and 3/4 struggle with weight. 20% greater hypertension prevalence, and more likely to report other chronic health conditions. So you have a population that has a high burden of chronic illness going into the system. And if you look at infectious diseases, so you look at rates of sexually transmitted infections like chlamydia and gonorrhea, 3 to 5 times that. 1 in 7 people with HIV will pass through a correctional facility in a given year. 1 in 5 with hepatitis C. So people may look at this and say, well, gee, that's infectious diseases, why do we care? Well, we should all care about this because 95% of people who are imprisoned are released. And if they are sick with an infectious disease that is uncontrolled and they have, in the case of HIV or hepatitis C, high amount of virus in their blood, well, that poses a community health risk because they're more likely to transmit to others. So folks with chronic disease, folks with infectious diseases, most of them are released to the communities and neighborhoods where they came from, and they bring their health challenges with them. So they are dealing with them, their families are dealing with them, the healthcare system is dealing with them, therefore we all are dealing with them. And also just to say something about incarceration itself as a health risk. So, it's not the best Shangri-La place to be, as we all know. Exposure to stress and violence and disease, limited access to health care. There's constrained resources for health care services. And if you look at the leading causes of death for people getting out of prison, number 1 is overdose. People being released from prison are over 100 times more likely to die of overdose in the first 2 weeks post-release than the general public, over 100 times. Most of that is for opioids, and most of that is because if an individual is addicted to opioids, they are incarcerated, and in general, I know that drugs sometimes can get on the inside, but in general, it's a period of relative forced sobriety. They are released, they don't have access to treatment, they use the same amount that they used to use, because that's what they used to need to get high, and their body can't handle it, and they overdose. So it's a tremendous risk factor for people coming out of prison. Also, cardiovascular disease, homicide, and suicide continues to climb. But I want to pay particular attention to the most significant health challenge that people who are involved in the criminal justice system face, and that's behavioral health, and what I mean by behavioral health, drug use and mental illness. So both disorders of the brain, both tremendous amount of clinical data, research showing these are diseases of the brain that we have effective treatments for. So if you look at surveys of local jails, 60 to 80% of people have former active current drug use. In Arkansas, more than half. So we struggle with this here in our own state. More than half of the people in our prisons and jails have a substance use problem of some kind. If you look at mental health, Nationally, about half of folks report a mental health problem. In Arkansas, some challenges getting good, reliable data. We know about 20% of people have serious mental illness, and what does that mean? That means something like schizophrenia, that means bipolar, serious depression. But there's some caveats that I would suggest that's probably a tremendous underestimate of the true burden, because if you look at how this typically breaks down across the country, you have people with mental illness that's been diagnosed, but then you have people with mental health symptoms, so any mental health issue, and then you see the rates significantly climb. So we have folks with diagnosed illness, but we have a lot of people who are unstable at the time of their arrest and the time of their incarceration. And ultimately, that leads to an unfortunate cycle that all too many people get involved in. And so you could sort of substitute a lot of things in here. I put behavioral health, it's addiction, it's substance use, it's also mental illness. So folks have an illness, they commit a crime, and that may either be simple possession, but it may be breaking and entering. It may be theft. Drug use is a terrible illness. It's the only disease, by the way, for which it's illegal to be sick. So people are going to commit crimes. Then they're going to get incarcerated. And if there is not sufficient treatment while they're incarcerated, either in prison or jail, or when they're released, they're not that good linkage to help them get the care they need, the chances are very high they will relapse. They'll go off their medication, they'll relapse to drug use, and the cycle will continue. And it goes around and around and around. And where does it stop? Nobody knows. But we can break that because we have effective treatments for both mental illness and for substance use disorders. We know what works. We also, as a community, know how to support one another. We can provide services and social support to people, to families that are dealing with a lot of these issues. And we can actually help people to reintegrate and recover long term. So it's not a hopeless cause here. And then the other thing that I always talk about, I know cost is a very it's kind of a can of worms because it's hard to really get accurate numbers for costs of the correctional system. But I just want to talk a little bit about just one part, the health care. So spending, and this is sort of our tax dollars, all of us, so even those of us who may say, well, why should I care about incarceration? Well, your taxes increasingly are going to incarceration, all of our taxes, and a big chunk of that is health care. One quick example I'll give you, hepatitis C. A large number of people with hepatitis C, it's a virus that infects the liver, are incarcerated. Biggest risk factor is drug use. And a course of hepatitis C treatment is $80,000. So you can imagine that you can't treat a whole lot of people before your correctional health budget is done. So it's a difficult situation to be in. And part of it is, this is a little bit difficult to see, but part of it is there's an aging prisoner population. Back in the 1980s, as I showed you with that slide, when we saw the takeoff, the real aggressive policies around drug use and mandatory sentencing practices were really adopted and aggressively pushed. So you had people that are serving longer sentences, and they're getting older in prison, and they're already sick to begin with, and they're getting sicker. So they require more health care, and health care is constitutionally mandated for prisoners. So we now have, it's law that we must provide health care to prisoners. And in Arkansas, this was a report in 2013 by the Pew Foundation. They looked at a period of 7-8 years, and Arkansas was one of the states with the highest increase in medical costs, about 90%. So we in Arkansas are really experiencing this in a big way in terms of how much of our correctional dollars are actually going to health care. So, focusing a little bit more on Arkansas. So, what is our situation here? How do we relate to the states around us? And what are we going to do about this? Well, we are a state that relies very heavily on incarceration. As was said previously, with the highest rate of incarceration increase in imprisonment over the past year, the third largest increase in our jail population, behind California and Texas. Those are two of the major states in our country. So, we're vying with them. And this, I pulled this from the Council of State Governments, as many of you may know, has been in Arkansas working with the legislature, and there's a criminal justice oversight task force chaired by Senator Jeremy Hutchinson. And they have given some really nice presentations over the recent months around the situation in Arkansas and what we can do about it. And this was a slide I found interesting because there's a lot of debate, especially now, around public safety and public health. And we need to maintain the levels of incarceration to keep our neighborhoods, our cities, our communities safe. Well, as you can see from this, our rates of incarceration are much higher than our neighboring states, and our neighboring states are seeing more dramatic declines in crime. So there are a lot of debates in, the crime and whether or not it's going down, whether or not it's going up. Is violent crime on the rise? And that's a whole nother lecture that I don't want to get into. But I just want to emphasize here, it is not necessary to have astronomical incarceration rates to have a safe society. There is not a correlation that we've really seen based on data, based on good evidence, where we can maintain the levels of incarceration we currently have and continue to see dramatic declines in crime. And in fact, neighboring states seem to be making a little bit more better progress than we are, and they're not increasing their rates of imprisonment in the same way. So it's something I think we need to think about. So, how did we kind of get to this point? Again, I'm going to defer to the Council of State Governments, who's, as I said, has been here and has really looked at a lot of the data that we have in the state around incarceration. And they highlighted 3 areas that I just want to touch upon very briefly. One, parole and probation violations. So it is the case, a lot of people say, well, we don't imprison people for, let's say, drug possession. So, okay, we put them on probation. Well, now there are a lot of stipulations that are associated with that person's probation. Any of those stipulations are violated, that person can go back to prison or can go to prison with whatever sentence they were initially convicted and the judge waived and said, I'm going to sentence you to probation instead. So we have a lot of people are being violated in the community for probation and parole violations, so they're going into prison that way. We also have some challenges with our sentencing structure. So there's limited guidance to judges in terms of what are appropriate sentences. And this is one of the biggest critiques for mandatory minimum sentencing is it takes away judicial discretion. So I can no longer decide what I think is a fair punishment. I'm mandated to assign a punishment based on a certain amount of drug in your possession at the time of the arrest. So what this has resulted in Arkansas, we have a large number of people who are nonviolent offenders who are serving very lengthy prison sentences. So again, we think if people are the violent offenders, well, we have a lot of folks who are nonviolent offenders who are serving very lengthy prison sentences. And we also, as pointed out, have some challenges in community corrections where community correctional officers, sometimes upwards of 130 individuals per caseworker. So that's a lot of pressure on community corrections. So 130 people that you are supposed to maintain adequate supervision over is an incredibly challenging task. So they need a lot more resources and support to be able to effectively do their job. And all of these things, there have been specific recommendations made as to how we can alleviate some of these problems. And so now we have this choice. And I like to think of it based on an example that happened with mental health back in 1972. So some people in the mental health field may be familiar with this massive movement to deinstitutionalize. Basically, let's take everybody out of these really creepy psych wards, and they're really bad, doing all of these, electric shock therapies and all of this stuff, and so let's get them back into the community, and that's going to be a better way to serve them. We can provide better treatment, better support, so let's deinstitutionalize. Well, that's great, but there needs to be an appropriate and commensurate investment in the community. So there needs to be treatment, there needs to be those supportive services for folks. And what happened, there was a huge disconnect. So that investment was not made. Thousands and thousands of people were released from these psychiatric institutions, became homeless, became unstable. So what happened, they started committing crimes. And the crimes are everything from disorderly conduct to aggravated assault to, in some cases, murder. So now we tried to deinstitutionalize, but we didn't really do that. We just sort of switched from one institution to another. What's the other institution? Jails and prisons. The three largest mental health institutions in the United States today are Rikers Island Jail, LA County Jail, and Cook County Jail. Those are the largest mental health institutions in our country today. So we did this movement of deinstitutionalization, but we sort of just shifted people. So again, we're faced with a choice. Do we invest in the institution to hold people, or do we invest in the community to treat people? So it seems that we're choosing one or the other. So how can we work on this? So how can we get a handle on this and make some progress, some real substantive change? Well, if you think about the criminal justice system as a continuum, there are a lot of different opportunities. So, kind of looking at this, and it's kind of cut off a little bit, but first there's sort of entry into the system where, you're arrested, come into contact with law enforcement. Then there's the prosecution part, pretrial, sentencing. Then you've got adjudication of trial. Then you go to the sentencing part with the judge. And then you may be sentenced to a correctional institution, and then you're released at some point, to reentry. So this is a broad continuum, and at each point in the continuum, we have opportunities to intervene. So whether it's looking at the time of arrest, giving law enforcement officers the tools that they need, whether it's crisis intervention training to deal with individuals with mental illness, better screening for folks, then the prosecution, pre-trial diversion type programs, I'll talk about a little bit more in a minute, the sentencing, specialty courts, and so forth. So there are a lot of different points where we can intervene. So that's the good news, that each area has its own unique set of challenges that we have to consider, but there are a lot of opportunities here. So I just want to highlight some of those opportunities, and this is kind of the call to action. Here are some things that will work. Why do I say will? Because they are working in other places. So we have a good amount of evidence as to what works. We just have to decide whether or not we want to do it and how committed we want our investments to be. So pretrial is one area, and in pretrial, the idea is I come into contact with a police officer and I've committed a crime. Let's assume, for the sake of argument, it's a nonviolent offense. So now that law enforcement right now, and I've talked to many police and local sheriffs who will say, look, there are no options. I either take someone to the emergency department if they're having a psychotic episode, or I take them to the jail. There's nowhere else for me to take them. One place, if you have pretrial services, you involve behavioral health providers in the community. So at the time of the arrest, police officers know, first of all, they've been trained to interact with people with mental illness. They know the resources in the community. Those resources are available. Some model programs, I was part of a program in Rhode Island where actually a behavioral health provider had licensed clinical social workers in the police cars during patrols. So that's one model. And here are 3 counties in Colorado, Tennessee, and many people may be familiar with the San Antonio model in Texas, that do some degree of this. They look at, okay, we train our law enforcement officers to, when they come into contact with someone who has an active addiction or has a behavioral health problem, how they can interact with that person. Then there's sort of behavioral health emergency support services available. And we come up with a plan. We don't take them to jail. We don't take them to the ED where they're going to be discharged at 3 a.m. We take them to an actual place where there can be a comprehensive treatment plan developed. So, these are collaborative practices that happen on the mental health side and the drug treatment side. The city of Seattle has been implementing a program called Lead Law Enforcement Assisted Diversion. You can possess up to 3 grams of crack cocaine, and the police will give you an option. Traditional prosecution, you'll be arrested and go the traditional route, or you can go to drug treatment. So law enforcement is doing this. And already they've observed significant reductions in recidivism among the people who participated. Another area, crisis stabilization centers. I was part of a group, and many people here are part of a group that met for quite some time. It was a coalition of community mental health providers and county sheriffs who said, you know what? The worst place for someone who's mentally unstable is a jail cell. It's a danger to the individual, to correctional staff, to jail staff, and then when somebody gets out, they're usually more unstable than when they went in. So crisis stabilization units, and when I lived in Rhode Island, I also worked on helping to develop some of these. These are short-term facilities, 48 hours to a week. Somebody is off their psychotropic medications, you can stabilize them. You can come up with a comprehensive treatment plan, plug them back into services. And some people would say, well, gee, we've seen the same people 50 times and, it's a revolving door. Well, that's the nature of some of these illnesses that we're talking about. It is a revolving door. And you know what? And I've seen this. 50 times someone may be going through a diversion program and going through one of these type facilities, and the 51st time they go into treatment. You never know. And at the very least, they're much more likely to get the support services that they need in a facility such as this rather than in a jail cell, and usually at a lower cost, and it's safer for everybody involved. Numerous states in our vicinity have these. Mississippi has numerous crisis stabilization centers, Oklahoma, Tennessee, and I know that this is something that a lot of people have been advocating for here in Arkansas, because again, it gives law enforcement a critical tool. Where do I take someone at 2 a.m. when they are very unstable and they're a threat to themselves or to someone else? Very limited options right now. Also, greater flexibility and discretion for both prosecutors and judges. And so some of this refers to specialty courts. People say, well, drug court, we've got 40 drug courts. There's a huge amount of variation across drug courts. So drug courts, contrary to what most folks may think, they don't work as well for low-level marijuana offenders. They work better for higher-level crack offenders because there's a more intensive supervision that's involved, and people with more severe addiction require more intensive supervision. So in order for drug courts to maximize benefit, A, we have to make sure that the right folks are getting into drug court, and B, we also have to provide that the right treatment resources are there. And part of that requires having a clinician based in courtrooms. Part of it requires partnerships with judges so they understand more about mental illness and about addiction, and also on the part of prosecution, and knowing that certain types of sentencing may not be to the best benefit not only of the individual but to society as a whole. Just because we can put someone away doesn't mean that's always the best response. And finally, just to point out the discharge planning, which It goes without saying, but this is often a missed opportunity. And right now, we know that just providing prison-based educational resources can reduce recidivism by up to 40%, and we're doing a lot more of that in Arkansas, and we're going to continue to expand. And Community Corrections is developing this model of reentry centers that many folks may have heard about. We're still sort of waiting. The jury's still out, so to speak. We need to sort of be able to evaluate these to see if they have an impact on recidivism. But perhaps the biggest area, and maybe the area we have the furthest to go, and when we need collective action and advocacy, is around treatment capacity in the state. So we can have our crisis stabilization units, we can train law enforcement to respond appropriately with people in active use. We can educate and inform judges and prosecutors and sheriffs. We can have these wonderful partnerships. But if we don't provide the treatment in the community, we are going to be severely limited. So that is the area where we have to make some real decisions. And so we can't just say, well, we're going to make investments in XYZ. This has to be a very serious commitment. Because right now, frankly, our treatment system in Arkansas is very limited, particularly for drug addiction. It is severely limited. And even now, even though there's public comment in Medicaid, we still don't have a Medicaid program that will fund drug treatment. So if somebody who's involved in the criminal justice system has Medicaid, and it's most likely they're going to get Medicaid because of the income restrictions and requirements. So suppose they're mandated to treatment. They can't get into treatment because they can't pay for it. Say, well, you need to get insurance. We have the private option. Great. My Medicaid does not pay for drug treatment. So then you'll go to prison. So we have to decide if we're okay with that. Right now, we seem to be okay with that because that's what's happening. I've also talked to people across the state who have told me that, I talked to one person a few weeks ago. My son has a heroin addiction. My son's best friend died from an overdose. I am paying over $600 a month out of pocket for buprenorphine because my insurance plan won't cover it. Buprenorphine is a medication used to treat opioid addiction. It's extremely effective. It can be delivered in a primary care setting, but yet we have a scarcity of providers. So we've talked a lot about a state. We have this opioid epidemic as a nation. We've been talking about it. We talk from the DEA side. We need to make sure that we're shutting down the pill mills, which, yes. We need to educate prescribers. Yes. We need to make sure that we're providing better, more effective alternatives to pain management. Yes. But what happens when we shut the supply of pills off? Yeah. And we're already seeing the increase in the numbers of people using heroin. So if people have an addiction, heroin's a lot cheaper than OxyContin, especially on the street. A lot cheaper. So we sort of have this perfect storm brewing, and we're lucky in Arkansas that we haven't seen the rates of overdose that even our neighbors Tennessee has seen. But if we have the 6 most opioids that are prescribed per capita in the country, and we have among the fewest number of Suboxone providers in the country to treat opioid dependence, something's got to give. So we have insurance plans, and we have this great act that was passed in 2008 called the Addiction Equity and Mental Health Parity Act. And it mandates that if you cover drug treatment and mental health, you're supposed to cover it the same way you cover any other chronic illness. But we have numerous insurance plans that are not covering addiction. So that's something we have to figure out a way to change that. And then finally, we have a relatively small slice of the world's population, 5% of the world's population, and a quarter of the people in prison. So we're not going to be able to incarcerate ourselves into a safer society. We can't incarcerate away fear. We can't incarcerate away addiction, mental illness, all the kids who have a parent who is locked up in a prison or jail, and the 1 in 3 African American men who are going to struggle the rest of their lives to even get a job. So now we have a choice, especially when we know what destruction incarceration does at the levels we're doing it. And I will just have to point out, I'm not an advocate. I'm not saying open the gates, release everybody. There are a lot of people that are dangers to themselves and to others. I think most people, we can agree on that. But at the rate that we are incarcerating people, when we know there are alternatives that are effective, then we've heard this record before. So my call to action to all of you is, I think, letting folks know, I've been told many times, it's the great thing about Arkansas is, legislators are within an earshot and they pay attention to people. So I think, this is going to take some state investment. We can't just write a big grant and get a bunch of funding. This is a state issue. It's a national issue, but we also have to make decisions as a state. And our governor has said, that he feels the foster care situation is a problem. He's spoken about addiction. Well, we need to see a significant investment in community-based treatment in order to reverse this. So, and also I would say that we all kind of need to be in this whole thing together, because it's going to affect all of us. So it's one thing, there's individuals that are involved in the system, but as I mentioned before, the downstream impacts are significant for all of us. So that's all I got. So any questions, comments?
Yeah. Thanks, Nick. We got time for questions. There's a question right over here.
I urge everyone to read an article that was published in the Democrat Gazette on Monday about a woman who has been working in the prisons for over 30 years. Her name is Anna Cox, and I happen to be married to her. There will be an appreciation event tomorrow night at Trios at 5:30. My question is, what is your assessment of the effectiveness of the CRA program, that's Certified Religious Advisors, in the prisons? Because that's the way that Anna Cox has used to go in and counsel with prisoners, including Damien Eccles on death row. And I know that her efforts have made a profound difference in the way prisoners have managed to cope with the conditions within prison and come out of prison with more options than just going back in terms of recidivism.
Yeah, thank you for your question. In terms of the overall effectiveness, partly I can't personally speak to that because I haven't actually seen any work on the evaluation of programs like that. I can just say, and we were actually talking about this earlier, anything that humanizes people that are in the correctional system is crucial, because folks, we all have spiritual dimensions, and because we are incarcerated, or because we made huge mistakes in our lives, doesn't remove that spiritual component, which is often very much damaged when people are inside. So I think, I've heard countless stories from folks across different faiths and spiritual traditions having tremendous impact. So, anecdotally, I think it can have a huge benefit. From a research perspective, I can't really speak to that because I'm not familiar with evaluations that have looked at large numbers of folks and how they've responded.
Yes, I just want to know, how is it possible for public health to collaborate with the criminal justice system to alleviate the cycle of carceration and reincarceration, and if so, how?
So, great question, and I think, I've only been in Arkansas about 2 years, and I've tried to meet as many folks as I can, and I know that everybody has their own approach to working on any particular issue, but I have tried and will continue to try to talk with folks at Department of Corrections, Community Corrections, sheriffs, because ultimately I've spoken to a lot of folks across the state that they want to do something differently. They recognize the problems, but they're very limited in terms of options. So I think one of the important things is to kind of think about getting rid of this divide that seems to be often present between public health and public safety. People who are healthy, we can have a healthy community that also is a safe community. These two things do not have to be antithetical to one another. They're part of the same thing. So I think most people want our communities to be safe. We want to promote wellness and health. And I think part of that is going to be, what is the evidence of what works and what doesn't? And to sort of stop and think and look and say, what we're doing is not working. And that takes a particular amount of courage, frankly. I know for me, and when I have to stop and say, gee, I'm taking the wrong approach, or I seem to be making the same mistake, that takes me a lot of courage to say, and that's on me. I need to rethink this. So I'm very hopeful that we can develop partnerships between public health and corrections, because ultimately, in many respects, we have similar goals and strategies. So my goal as someone who's in public health is for people who have significant illness to get appropriate treatment, and in many cases not wind up in the criminal justice system, because that's going to generally make things worse for them. And a lot of people in the criminal justice system have a lot of frustration not having the tools and resources they need to adequately manage folks they have with very significant behavioral health problems. So working together, I think, should be, I hope, straightforward.
Speaking of behavioral health issues, I think that when we talk about choices that we have to make, I think it's very clear that the current administration in this state and also the legislature have decided that they would rather systematically gut mental health and behavioral health services in this state rather than to invest. So I think that that's a choice that's being made as we speak. I also want to say, as we know from this past election, rhetoric matters. When we talk about behavioral health and we talk about people with mental illness in the criminal justice system, statistically, someone with a mental illness is 12 times more likely to be the victim of violence than the perpetrator. Yet many times we use the idea that people with mental illness are violent in order for us to be able to maybe try to secure more funding or to try to get more support with mental health services. How do we begin to have that, bridge that discussion that we remind people that just because you have a diagnosis of bipolar disorder or schizophrenia, you're 12 times more likely to be the victim than the perpetrator of violence, but yet we use that rhetoric in trying to get support for funding? How do we blend those things?
Yeah, it can be very tricky. I think part of it is understanding the nature of mental illness and substance use, and I think we still have some work in that regard. I find often people don't have an adequate understanding of how mental illness really can be debilitating for people. And on an individual level, even with someone with serious mental illness or serious addiction, there are personal choices that we all must make. We have to make the choice to want to get better, but we also have to have the opportunity to get better. And I think it's easy to label folks with behavioral health disorders as all this or all that. And I also think fear is one of the biggest problems. And it's one of the biggest challenges with criminal justice system. It's one of the biggest challenges that we're dealing with across the country today, as this last election showed us, that there's a lot of fear on all sides. We're very afraid of each other. We're afraid of people who are involved in the criminal justice system. It's easy to make them all out to be murderers and rapists and to dehumanize them. But I think the more we can understand the nature of mental illness and the chronicity of it, the fact that these things just don't go away. It's like diabetes, folks have to take insulin their entire lives, and we're like, okay, that's a legitimate medical illness, you have to take insulin. I have to take an antidepressant my whole life. Well, is that legitimate or not? We still have these open-ended questions, particularly around drug use. Not all drug users are violent. Not all people who are in possession of drugs are violent offenders. And I think that it's a lot easier to use fear, and we've done this throughout history, use fear to label things we don't understand. And I think that's going to be, it seems cliche, education, but we all say it and we still are not educated. So clearly, for whatever reason, we struggle to really embrace knowledge and information about things that we don't understand.
Yes, ma'am, got a question right back here.
Yes, I have a question regarding the data, the epi story you gave. Does that include youth and juveniles?
No. So most of this presentation was on adult offenders. The juvenile system is a whole nother situation.
Well, I was going to ask you if there's some suggestion in moving forward in that arena, because that kind of also adds on to the already burden of incarceration. Can you speak to what the situation is in terms of juvenile pipeline to adult prisons?
Well, I think you have many of the similar issues, and it starts, and actually it starts in schools. In fact, people getting arrested in schools, and we see the same disparities that we see in the adult population and youth population. And unfortunately, we know that when people start to get involved in the juvenile justice system, they're much more likely to get involved in the adult system. It's not always the case, but the juvenile system in many ways mirrors the adult system. So there's a reason why there's been a lot of emphasis in recent years on the school-to-prison pipeline and this phenomenon, because it exists. And for many kids growing up in certain neighborhoods, they're more likely to be in prison than they are to graduate from college. So that is a very real thing. And I think it comes down to similar things that we were talking about today, but reconfiguring it and tailoring it. So again, the behavioral health component, people who are acting out in school, why? What's going on? Where are the supports that are needed? So I think it's all part of a larger system that's predicated on physically removing people from society rather than providing adequate treatment.
Listen, I know we got a bunch more questions. But it's past 1 o'clock and some people have to go. So please come up and visit with Nick afterwards. He's going to be around for a while. I want to say thanks to the UAMS, the Boozman College of Public Health, for helping us with this program. We have a concurrent degree in Master's in Public Service and Master's in Public Health, and it's an honor to work with the School of Public Health. And they got great professors like this guy right here. Please welcome and thank Nick Zaller.